I was listening to Bhavesh. It was a it's a pleasure to listen to Bhavesh, who has done wonderful work on perimembranous VSD. Number 1 was prophylactic steroids, and number 2 was wire maintaining technique. Both were his contributions, and it's wonderful to hear Bhavesh talking about it. My colleague Dr. Anand will now give the case presentation of the first case. PowerPoint big.
Good morning. Our next case is a 49-year-old female, mother of
Anand, you can present.
Sir, is it audible, sir?
So, by the time case details, we have panelists here, Dr. Rita, Dr. Bhavish, Dr. Prashant, and also Shushil, myself, Professor Jairanganath, and Dr. Bhavesh Thakkar. So, we are 7 people here. Please go ahead with the presentation.
Good morning to each one of you, Dr. Rita, Jairanganath, Sushil.
Good morning, sir.
Good morning.
Anand, go ahead, please.
Our next case is a 49-year-old female, mother of 3 children, who presented with complaints of class 2 exertional dyspnea and fatigue for last 1 year. She had no palpitations, chest pain, syncope or cyanosis, no significant medical history in the past during childhood, and her pregnancies were uneventful. On examination, she is a thin-built lady who is hemodynamically stable, and on examination had cardiomegaly, normal S1, a widespread S2, and 3/6 ejection systolic murmur in pulmonary area. Her X-ray or ECG showed normal sinus rhythm with a PR interval of 200 milliseconds and a QRS axis of 60 and RSR dash pattern in V1 with normal ventricular forces. Her chest X-ray showed a CTR of 50% with prominent MPA and branch PAs and plethoric lung fields. And now my colleague Dr. Pramod will show the echocardiography in live.
Good morning. Now T big. Yeah. Now we can see the T images. Now we are above the level of the atrial septum at 0 degree. This is the RPA, this is the SVC, and this is the aorta. I am advancing the probe further. Now we can see that we see the first defect here. It is located anteriorly and superiorly. And this is the color flows that is shunting left to right. And we can also see that the retroaortic rim is deficient. Now I am advancing the probe further. When I am advancing further, we see the second defect here, which is located posteriorly and inferiorly. To get both, I am moving the angle to 60 degree. In the 60 degree view, we can see both the defects, a larger anterior antero-superior defect and a smaller postero-inferior defect. And this is separated by a tissue which is quite thick and it is longer. The tissue in between was measuring 13 mm when we measured in the OPD. Again, we can see it's around 12 mm here. And the antero-superior defect measured around 19 millimeter and the posterior defect measured around 12 millimeter in the OPD. We can see both the defects now with the color. This is the antero-superior and this is the postero-inferior defect separated by a tissue that is larger than 7 millimeter. So we will close this with 2 defects. We can also see that the posterior margin is present here. There is a posterior margin, and otherwise, other than the retroaortic rim deficiency, other rims are present, and it is feasible for device closure. Now over to Sivakumar, sir.
Thank you, Pramod. Nageshwar, now we are showing the. Can you make the big screen? Yeah. The patient is under anesthesia to facilitate a transesophageal echocardiography. And because the patient is on artificial ventilation, we decided not to do a QP, QS, but we are going ahead with the PA pressures. The pulmonary artery pressure is shown in blue color, which is around 29 by 8 with a mean of around 18. And the aortic pressure is close to 140 by 80 with a mean of 105. We have 2 venous accesses to facilitate 2 sheaths from the groin. So on the right
Shiva,
femoral
that's
vein, we
very
have,
good. Let us take one
yep.
or two points from the floor and other moderators from other side before you. What is your plan?
Yes.
So you may be having a very quick picture of 3D, no? Do you have that? You are going to show 3D.
Pramod, you can.
Yeah,
You can
why
show
I
that.
ask 3D, several times this 2D, sometimes you think that one device is sufficient or the device overlap and all. 3D will show you the area actually, especially in multiple ASTs. For a single AST, I don't think it is going to be useful, multiple ASTs. Do you have any question, Bhavish, Rita? Any questions from the floor? So there are no questions, you can go ahead with your plan.
Yeah, so Dr. Pramod is now getting the 3D on-fast view. One of the problem about 3D on-fast view of atrial septum is, if the septum is very thick, it gives attractive images. If it is a thin floppy septum, it gives very faint images which are not extremely good. But Pramod is now increasing the gains in order to get a better quality TE image. As he was preparing, in the meantime, you can observe that I took my catheter into the superior vena cava, came down from the superior vena cava and walked into the first defect, and I have the wire catheter through the first defect. We are going to do a balloon interrogation using the LifeTech balloon. Show the LifeTech balloon.
But Shiva, fundamental question here. Since you have 2 defects, 2 are moderate, one is 20 millimeter, another is around 13 millimeter, and there's a good separation between that, there's a large rim is there. In a regular, routinely, we stop doing a balloon interrogation for all these cases except a floppy rim where redundant septum, PFO, those things. Here, do you really think balloon occlusion is going to give idea, or we can close the 2 devices like any of the single? I feel that my assessment is,
actually,
your 2D assessment is fantastic. We can go ahead with the 2 devices rather than, maybe you can show live, that is different. But from the scientific point of view, I want your opinion.
Yeah, just about, I think in the last issue of Annals of Pediatric Cardiology, Pramod Sagar, who is doing the echocardiogram, presented our experience on multiple AST devices in about 28 patients using 2 devices. He enumerated the reasons why we do a balloon sizing. Number 1, when we do a balloon sizing, we are actually occluding the first defect, and we ensure that the second time we are crossing is not through the same hole, and we are crossing through the second hole. Otherwise, there are a small number of occasions where you will notice that we would have assumed that the first wire is going through the first defect and second is going through the second. But after positioning the sheath, we will recognize that both are through the first. So one of the way in which we tackle this is, we first go in. So this is a sizing balloon across. We inflate the balloon till we get a waist. And the moment we start seeing a waist, we stop there, and then we cross the second. So now we are definitely sure that we will not be crossing through the same hole twice. This is number 1. Number 2, in majority of the patients where there are double ASDs, the atrial septum is slightly floppy, and hence they tend to have second RCA catheter. They tend to have more stretchability, because the basic nature of a double ASD itself is because of extreme floppiness of the septum. In fact, fenestrated septums are even more floppier. Multi-fenestrated septums are even more floppier. So the advantage is that we will not twice cross the same defect, and number 2 will be able to assess the floppiness far more better. Now I have slightly inflated and I have left it, the balloon for Pramod to interrogate, and in the meantime I am planning to cross. The previous defect was a little bit more inferior, so now I am trying to cross it from a little at a lower level.
Our experience,
Walking into the pulmonary
what I want
artery.
to tell you is there are multiple methods. The IVC defect with multi-purpose catheter, if you take and go from IVC, the posterior inferior defect can be straight away closed, because you all know that fetal circulation, IVC flow goes to the LA. So that's why multi-purpose catheter straight away goes there. Probably the right coronary, Judkins right coronary will have tertiary care, it doesn't allow you to go. Second is the inflated balloon.
Yeah.
It is not that only across the defect, it is in the area also. It prevents sometimes your catheter to go through the desired defect. So what we practice our center is this kind of, I agree with Shiva totally that balloons are important when you have close by, and what he is demonstrating also is perfect. So the alternative methods, you go from SVC and then cross the anterior superior, go from IVC and cross that, maybe reasonably good alternative to the what the methods are being demonstrated today.
I cannot disagree at all with you, Nageshwar. Your points are quite valid. A large inflated balloon within the right atrium is going to be a space occupying lesion in the right atrium and try to prevent us from engaging. But the points that we did not want to double cross the same defect, and number two is it gives a slight idea about the floppiness of the septum. Now what I have is a second wire, probably through the second place. Pramod, can you
Yes,
go to your 60-degree view, open out the two defects and find out. I am going to put in a second balloon into the second defect now. Did you show the LifeTech sizing balloon for the audience?
Can you go to fluoroscopy little bit LAO angulation so that two wires can be separated? In anterior posterior projection, it looks
Yes.
overlap. So people may see that two wires to be separated, anterior superior and posterior inferior, if you change the fluoroscopic angle.
Yes, I will just do that now. I am getting my sizing balloon inside. The moment I get it, fluoroscopy to LAO. Pramod, the fluoroscopy is moving to LAO. Adjust your T probes. Is this a 34 millimeters?
Now there are three sizing balloons available from LifeTech. I think 18, 24 and 34 or 36. 34. Even we
Yeah,
rarely use.
24 and 34 I am aware of.
Yeah, 18 also there. 18. Amplanter
24
or LifeTech. 18 is
Oh,
there we
okay.
use.
Press there. Press there. We
Yeah,
are
that's
now
a nice,
showing the
nice
LifeTech
fluoroscopy.
sizing balloon.
It's a wonderful fluoroscopy view. We can definitely see separation of the two wires. Sushil has got.
Aspirate, ma?
I wanted to ask, my question is related to the sizing of the defect. Do you size primarily based on the echo, or do you use the based on the fluoroscopy or the echo
Echo.
T after balloon operation?
Echo is the primary one.
But I saw
Echo is the primary mode of checking.
But I saw somebody measuring
Echo
the
is the
waist of the
primary
balloon.
mode in our out.
You don't.
Waist also we will measure.
Shiva, what is the rationale using a second
We
balloon?
will measure the weight.
Shiva? Shiva?
Now I'll show you. Now what I am going to do is, I'm hearing you. Jai Ranganath.
Yeah. Now what is the rationale? I mean,
Jai
first
Ranganath,
balloon-
are you able to hear me?
Yeah. First balloon is fine, that your all concepts are very good, that we also do at times, that's most of the times. So the second balloon, is there any rationale of using, because the audience would like to know, when you already have some
The
idea.
2 points.
Points, yeah.
Slightly take out the TE probe. I initially mentioned that the 2 reasons why we do record this one. measure this. The two reasons why I mentioned was, number one is to avoid crossing the second defect, and number two, majority of the secondum ASDs are across floppy septum, and hence they may be larger than what you anticipate on transesophageal. The largest dimension that we got in the transesophageal for a superior defect was 19, and for an inferior defect was 12. So here we just want to reconfirm that we are not having, this looks smaller. Pramod, okay, actually there was I think stickiness of this balloon. Let me,
What is the size of the balloon? Second
I
balloon?
have to pull out.
What is the size of the balloon? 34?
The second balloon, actually I wanted 24, but it was 34.
Yeah, it looks big.
Just little bit above, little bit up, little bit.
In the presence of floppy septum, don't you think this balloon sizing would be little more over than the size on the T?
But that will only give the stability, no, Sushil. If suppose if I have a little floppy septum and I have a size of 12 and I target my device for a 12, and unfortunately if that floppiness of the septum is not supporting my device and the device later slips through, that is the purpose of the interrogation itself. Measure this second one, measure the first one. We are taking out both. Pramod, now I am occluding both. Can you confirm that there is no third defect?
Yes, sir.
This is the third purpose of a sizing balloon. A good number of the patients who have multiple ASDs may have a third ASD which will be invisible in the first echocardiographic assessment.
Can you
any
show
blue
in
color flows
90
across.
degrees, because the entire heart is occupied by two balloons. We can't see the intratracheal septum. Can you show in multiple views 90 degrees?
Pramod?
Pramod?
Pramod, 90 degree color now.
90 degree now.
Color.
Because what
Color
happened, we have
and-
bigger balloons
and
than the
just
anticipated sizes, the 34 and 24 probably, that could be
Pull
the
out,
reason.
pull out to superior vena cava.
Yes.
So,
Pull out to superior vena cava. Yeah, now go inside, that's the right upper pulmonary vein. Go little rightward, get the superior vena cava. Yeah, you are now in the superior vena cava. Now just to push the cable, now rightward and leftward rotate. We are not finding a very significant blue color across. So we assume that these are the only two defects. Now my left femoral sheath is going through the smaller defects, which I am going to deflate now. Sister, get me a 10 French Life Tech sheath on the left groin. While one of my colleague is measuring the waist of both the balloons, I am exchanging it to two sheets. So while the first and second purpose of the sizing balloons across both the defects is to avoid the second crossing as well as assess the floppiness of the septum, after inflating both, the third purpose is to exclude a third ASD. Pramod has written an article in the APC on experience in closing secondum ASDs using multiple devices in about 25 patients, of whom 7 were pediatric and 18 were adults. And what were in fact there were 2 paragraphs that he has dedicated for balloon interrogation, and where he describes what is the rationale of balloon interrogation. Can I have one bowl of water for an underwater seal? I have with me Dr. Alka, who is a second year fellow, and now we are seeing blue color, which is because of the deflation of the balloon. We are de-airing the first balloon. Since the patient is on positive pressure ventilation, the chances of air embolism is relatively less in this particular patient than
can you
in a
please
patient
focus
who
on
probably
the
is spontaneously
focus
breathing.
the de-airing, please? The camera, bigger screen on the
Camera come down.
yeah.
Camera
Fluoroscopy
come down.
small and hands bigger size.
Hands bigger.
Yeah, we can see the de-airing. Do you routine? So what
As
is
yeah,
So the wire is still across and dearing. The check valve may not work properly in such case. What is the size of the sheath?
Check,
We have used
yeah.
what is the sheath which you use?
10, 10 French Life Tech sheath. Sister, take out the wire of this, that wire. Yeah. Slowly take it out. As she takes out, I am slowly injecting saline. Just stop, sister.
The major advantage is patient is ventilated, so that's why air embolism
Yes.
chances are less. So all ASTs, I think you should have good
Yes.
hydration, positive pressure ventilation should be there, and also preferably you should do in the morning. As the day advances, the RA pressure will go
Yes.
low, then you will have air embolism. So
Yeah.
it's a good idea what Sivakumar is doing. First case
Extremely-
in the morning, de-airing properly, and positive pressure ventilation is.
Yeah, extremely important points, Nageshwar, whatever you have told. Now we have taken out the balloon. Through this second wire, we are putting in the second Life Tech.
So do
What
you,
sizes have you decided, Shiva?
See, basically, the echo size was 19 and 12. What is the fluoro sizes? Show me the fluoro sizes. While I was putting in the sheets, somebody was measuring, and the fluoroscopy does not come to me because, okay, one is 24. Just 1 second. I will show you now after I put in the sheet.
very quick point, do you routinely use the braided sheets or you use Cook's Mullen sheet as well sometimes?
Quite a lot of time we will use a Cook Mullin sheet. Quite a lot of means maybe 90% of the time.
Okay.
Sir, Bhavik here, sir. I had a question. This sizing balloon you are
Yep,
advancing. You are advancing through the seat or directly through the groin without the seat?
Through the sheath. It was a 10 French sheath,
Okay.
10 French short sheath, which 10 French we will be using as the loader finally.
Another question, sir. Since he is 48
So again-
years, are you planning to take LVDP
Yeah.
baseline as well as post procedure or not? And coronary angio. These two things, sir.
We will do it. RA pressure was quite low, so I assume LA pressure is also low, and so the LVD will be low. I have an arterial line. Once I get my devices across, then I will be checking the EDP. Sister, wire out, sister. If the patient is having a high RA pressure, when I am advancing the catheter into the right heart, if the right atrial pressure is high, automatically left atrial pressure is high, and if the left atrial pressure is high, there is a strong indication that the left ventricular end diastolic pressure may be high. So if the RA pressure is very low, the LA pressure is low, and the LVED is also likely to be low. So this is the logic behind the initial presumption about is the patient likely to have a restrictive LV physiology or no LV physiology. It's very surprising to see a patient who is having an RA pressure of 1, 2, and 3 having a restrictive LV physiology. Okay, now we have two sheets across. So, sister, our pigtail catheter. We are, what is the, can you now show me the balloon sizes? I think one was 23.5. With the 19, what we got was 23.5. Show the measurement. Okay, one was 24, 23.55 or 24. The second one, show the second measurement. Okay, he is measuring live.
Good morning, sir. Rita
That's
here,
10
sir.
millimeter. No, take inner to inner 10. Inner to inner is 10. Yeah, correct. Inner to inner is 10. Yeah, Dr. Rita, you had a question?
Sir, on the 2D, after you did the balloon sizing, were you still able to appreciate a posterior rim, sir? It looked small in the initial, I mean,
Actually,
Beyond
the
the
inferior,
second
the
defect.
inferiorly located yeah, the inferior ASD does not have a margin, very good margin in the postero-inferior part.
yes, sir.
And so but we feel that all the other margins are adequate, that it will get anchored.
Sure, sir.
We'll see. We'll put the device and then we'll see.
Right, sir.
Shiva, Dr. Bhavesh here.
Pramod, have you measured? Yeah, Dr. Bhavesh.
Yeah. From your 25, 28 patients of multiple ASDs with the balloon sizing, did you find any equation where you can have idea about that the size is nearly 25-30% larger when we use the balloon? Some equations are there?
More or less like that, Bhavesh. More or less like that. In
Something
general, it is something like around 25% higher.
So did you find it is
Yeah.
same like a native single ASD?
Did you find it is same like a native single ASD? There are a few patients who have completely gone very big. For example, where we measure on echo a 18 millimeter and finally we ended up putting 30 device.
Oh.
In fact, on a couple of patients in that article we have described, a patient who was having a 20 millimeter hole, we decided to put in a 26 millimeter device. The 26 millimeter device embolizes, but then on balloon sizing, the diameter, the balloon stretched diameter was 28. And so we decided that we will go more by the echocardiogram and we are adding +6, but that was not adequate. So finally we ended up in that embolized device had to be retrieved and then we upsized it to 30 millimeter. So what we decided was use balloon in every patient with a double ASD. Now you see that the second picture is 12 millimeter. So a 12 millimeter inferior defect, I want a 14 millimeter LifeTech ASD device. 14. Show the device to the audience and give me the device fast.
Shiva, do you suggest to use the balloon in a patient with a
I want
floppy septum and a single defect?
No, that we don't use it, Bhavesh. Actually, I strongly agree with Nageshwar. We have completely come out of balloon sizing for a routine case. The cases where we do a balloon sizing are, number one is this double ASD where we do it always. Number two, in patients where we expect a restrictive LV physiology. Number three, in a patient in whom we expect elevation of the RA pressure due to either hypoplasia of the right heart or due to pulmonary stenosis. Actually, we are running short of time now. So let me make it little faster. Alka, the smaller device is on the left side, right? So now I am taking the smaller. Keep the second device ready. I want a 24 device. It was a 24 size, right? So give me a 26 device on the top. So I am upsizing by around 2 millimeters for the lower defect. Pramod, you are showing me the echo.
Yes, sir.
Okay. Now I want, 60 degree, that's fine. Track my device. No. I want, 0 degree. 0, correct. Yeah.
If you want,
Keep
you can
tracking.
change the fluoroscopy to AP view. We are okay with that. Maybe.
You are happy? Okay, please
Yeah.
come to AP view.
Yeah, I understand that a little bit of.
My working plane will be always AP view.
No, that particular time
I
I
don't even
wanted to
check in
show, demonstrate to you by that separation. Now it's fine, you can work in AP view.
Okay.
Because you can have
Okay,
better
now
orientation
show me
to
the,
deploy.
give me Pramod, check on the device.
But why did you deploy?
Can you
this,
take out the-
Probably you can take other device and simultaneously, which most of the times you also demonstrated some of the live workshops in the past.
Yeah, the intention in a small device versus a large device is, I try to sandwich the large device. I try to sandwich the small device with the large device. So here the intention will be to get the LA disc of the larger device on the left side and the RA disc of the large device on the right side. So I'm now getting the second. Pramod, you are happy about the
Yes, sir. Yes, sir.
edges?
Clearly. Yes, sir. Yes, sir. Yes, sir.
Okay, now show me. I am coming for the next device. Go to
Okay,
0
okay.
degree.
So the LA disc
Make it
of
smaller.
anterior superior, that is 24 device is being deployed in the LA and then catching the disc, sandwiching that
Pramod, show me left side little bit.
Yes, sir.
Left side.
Let us see. So now unsheathing of the bigger one.
Come,
24
eye scan and reduce the gains. The device is prolapsing the aortic margin. So I will take it inside.
If you go to 45 degrees of fluoroscopy, sorry, echocardiogram. Yeah, that's a very nice. 45.
It's
you can
prolapsing, Nagesh.
see. Yeah, I can see that.
Can you, Shiva?
Yeah. So now
Can you anchor it somewhere?
let,
pulmonary
let,
vein
let me rapidly deploy.
Or else you deploy and yeah, that's right.
I have
Deployed.
Mid LA position. You can
fluorostore
keep-
this.
That's a nice
Okay.
rapid maneuver. What Dr. Sivakumar has done, rapid maneuver.
Now
is
I'll show you the.
You don't tug it. You deploy and LA disc in the mid LA before to the septum and rapidly deploy. The RA disc will support the LA disc. RA disc will prevent the prolapse of LA. You can show that to fluoroscopy and explain, Shiva, what you have done.
Yeah, it is. It is being shown. Pramod, Nageshwar, it's being shown again and again.
Yes.
What I did is being shown.
Yes, yes. So you can see that
but-
AP view. The larger defect, LA disc
Pramod,
is
come
deployed.
to see.
0.
Now,
Okay.
Yes, sir.
So now Pramod is showing the overlapping part of the two devices. Color now, Pramod.
Yes, sir.
that
Okay,
probably
so the-
we
we
can
are
see
seeing
better
this,
in 90
you-
degrees or 45. Pramod, you can go TE little
Yeah,
bit
he's
different.
Okay.
he's now changing the angle.
Beautiful.
This is the
It is not sandwiching because the devices are little apart from each other, not very
the
close to each other.
inter defect septal is long. It's a good actually.
Yeah, I'm hearing the bell. So probably I think I'm running out of time now.
But
So,
it deployed
Pramod, if
very
you are
nicely.
happy, can I release?
You can release.
Yeah, show the left ventricular end diastolic pressure, LVEDP bigger.
We have 2 minutes time. We have 2 minutes. Moderator.
Beautiful case, sir.
Yeah.
Thank you so much for the demonstration.
Bhavesh,
yes, sir. It looks
thank
nice.
you, thank you. The LVED is marginally on the higher side. It is coming to almost around 18 to 20. But we need to remember that the patient is on positive pressure ventilation, which itself will increase the end diastolic pressure a small amount, like around 2 to 3 millimeters of mercury, because positive pressure ventilation tends to increase the intrathoracic pressures and leads to an increase in the end diastolic pressures. So we are confident that we will be able to get her out without any
Pramod, go to 90
need
degrees.
for leaving behind a fenestration.
Yes, yes. Yes, sir.
Yeah. Now rightward and leftward rotate, Pramod. Keep on rotating rightward. Yeah. Now you have gone leftward.
Yes, sir.
So go rightward.
Coming right.
Sir,
Further and
Bhavik here,
further.
sir. The
Now color.
inferior-
I'm able to
inferior
see the. Yeah, Bhavik.
device through the inferior defect, you often see that angulation which we are not usually not comfortable to see. That inferior device, it looks at particular angle, so it looks like it's not sitting properly. But I'm
Actually,
sure
now he is focusing on the inferior defect completely. Color now the inferior defect. Okay. The moment I release the cable,
Dr. Shiva, you will have
then
to hurry
probably
up.
it will
Dr.
fall
Varakan
in
is ready
place.
with the case. The case he's saying very sick, so we'll have to move to Dr. Varakan, so you can release fast so that we can move.
Yes, sir. Okay. Now I have released. Now Pramod, show the echo.
Yeah, that's a beautiful demonstration of
inferior device.
multiple defects by Dr. Sivakumar and his team, Dr. Pramod, everybody. Wonderful. I think with the interest of time, we'll move to other center because patient is sick. Maybe when you come to second case, we may ask a question, Shiva. Is it okay for you?
Okay. I'm fine. Pramod,
Yes, sir.
but Nageshwar, we have completed the procedure. We
Yeah.
are now showing the echo. I think please go to Dr. Varakan.
Yeah,
He will have interesting
absolutely
work.
fine. Give him a big hand, actually. It's very nice. Great job, Shiva. Great job. Okay, please move to the next session.